Hello.
Doctor, you're audible.
Yeah. Okay. Thanks.
Doctor, please rename yourself. Your full name.
Mm,
Just click on the top of your photo
yeah.
image.
Is the screen visible? No. Is the screen visible? The screen
Yeah,
I'm sharing now.
it's visible. Make it to full
Okay.
mode, full screen mode.
Should I make
Going
it
to small.
background effects? Sorry, this is just just a minute. Now, how should I make it? Any idea? Video?
Doctor, you're on your laptop, right?
No, I am not on laptop. I'm on my cell phone. Shall I join through my laptop? Yeah, wait, I'll
Yes.
join through my laptop. I'll cut and join through my laptop.
Yes.
Audible now. I have joined through my laptop. Hello?
Yes. Kindly rename yourself. I'm not able to see you.
Hello?
Is your camera working?
Yeah, my camera is working. Just a minute, I'll come wait. Just a minute. 1, 2, 3. Yeah, am I audible now? Yes, I will start sharing the
You are
screen.
audible, doctor, but you are not visible.
Yeah, just a minute, wait. Just a minute, wait. I will. No, I'm just downloading sir's PPT. Am I still not visible? Hello? Hello?
You're not visible, doctor.
Still I'm not visible. No, the video is coming for me. Video. My camera is turned on only. Laptop camera Zoom meeting தான் open பண்ணிட்டேனே அது வீடியோ ஓகே அந்த வீடியோ நான் இது பண்ணிட்டேனே
ஷேர் ஸ்கிரீன்
அது ஓகே அது இது Can I log in through my cell phone? Because sir's PPT I'm having through my in my cell phone. It will be easy for me to project in that. Hello?
Doctor, you cannot access the PPT on your this.
No, the PPT sir will be projecting. I will be sharing
Okay.
only the
Okay, then you can join through your phone.
sir's only the performer. Sir has not sent his PPT so far. Sir has only sent his CV. That's all. Yeah. Hello? Are you there?
Doctor, please rename yourselves. Your names are not visible.
Yeah, wait, agree.
சார் குட் ஆஃப்டர்நூன் சார். சார் இது நீங்க இந்த ப்ரோக்ராமுக்கு ஜாயின் பண்றேன்னு சொல்லியிருந்தீங்க போல சார். அதான் நிவேதா அவ அந்த இதுல இருக்கா, ஜூம் மீட்டிங்ல இப்பதான் உள்ள போயிருக்கா. அதான் என்ன ரிமைண்ட் பண்ண சொன்னா சார். சரி சார், சரி சார், சரி சார், சரி சார், தேங்க்யூ.
Sir, good afternoon.
Good afternoon.
Good afternoon.
சார் குட் ஆஃப்டர்நூன் சார். டாக்டர் கார்த்திக் சார்.
குட் ஆஃப்டர்நூன் டாக்டர் கார்த்திக். எப்படி இருக்கீங்க?
நல்லா இருக்கேன் சார். நீங்க நல்லா இருக்கீங்கல்ல சார்?
நல்லா இருக்கேன் டாக்டர். காட்ஸ் கிரேஸ்.
தேங்க்யூ சார்.
எத்தனை மணிக்கு ஆரம்பிச்சாச்சு டாக்டர்? going to be started?
In another 5-10 minutes sir.
Oh, sure. I think இன்னைக்கு attendance will be very thin because the match
போயிட்டு இருக்கு சார். எஸ் சார், இந்தியா பாகிஸ்தான். இல்ல சார், என்னன்னா சார், this is only for the panelists சார். இதுல வந்து மேக்ஸிமம் 10 தான் இருக்கும். ஓகே, வியூவர்ஸ் லிங்க் இஸ் செப்பரேட். தட் கோஸ் பியாண்ட் 500 போகும் சார். அது ஆல் ஓவர் இந்தியா. அவங்க வந்து சாட் பாக்ஸ்ல தான் தே கேன் இன்டராக்ட். இது வந்து டைரக்டா நம்ம ஜூம் மீட்டிங் மாதிரி இருக்கும். இது அப்படிதான் சார் வரும். இது நம்ம ஒரு இது பண்ணோம்ல சார், ஒரு பேனல் டிஸ்கஷன் பண்ணோம், ஞாபகம் இருக்கா சார்? அதுல நம்ம ஒரு 10 பேர் மட்டும் தான் இருந்தோம், பேனலிஸ்ட், ஆபீஸ் பேரர்ஸ். மிச்சவங்க எல்லாம் வந்து லிங்க்ல இருந்து சாட் பாக்ஸ்ல क्वेश्चन ஆன்சர் மாதிரி क्वेश्चन கேட்டாங்கல்ல சார், அந்த மாதிரி இருக்கும். இதுல வந்து only selected invitees தான் உள்ள இருப்பாங்க சார். மிச்சவங்க எல்லாம் வியூவர்ஸ் லிங்க்ல தனியா இருப்பாங்க சார். இது மதுரை சார், பட் இட் இஸ் a central IAP. நோ சார், சென்ட்ரல் ஐஏபி பிளாட்ஃபார்ம்ல மதுரை பண்றாங்க. சோ லிங்க் வந்து பேன் தமிழ்நாடு, பேன் இந்தியாக்கு போகும் சார். ஆக்சுவலி யார் வேணா ஜாயின் பண்ணலாம் சார். எஸ்
போய்ட்டு வந்தா சார்.
ராமணி சார் வணக்கம்.
வாங்க. வணக்கம் சார், எப்படி இருக்கீங்க? ஒரு நோட் எழுதுனேன். ஜாயின் பண்ணிட்டீங்க போல?
ஆமா சார், ஜாயின் பண்ணிட்டேன். இன்னைக்கு தான் ஜாயின் பண்ணேன்.
பீடியாட்ரிக்ஸ் லாஸ்ட் பீடியாட்ரிக்ஸ் again to தேனி மெடிக்கல் காலேஜ்.
டீன் குவார்டர்ஸ்ல தான் உட்கார்ந்து பேசிட்டு இருக்கேன்.
அப்படியே வா ஷிப் பண்ணிட்டீங்க அப்படினா?
ஆமா சார். இல்ல ஆமா சார், திங்ஸ் எல்லாம் கொண்டாண்டேன். I'll be staying சார். ஸ்டே பண்ற ஐடியால தான் இருக்கேன்.
பீடியாட்ரிக்ஸ் will miss you ல. the institute டைரக்டர் ரொம்ப மிஸ் பண்ணுமே.
ஐ சார், மிஸ்ஸிங் போய் நாள் அப்படிதான் சார் இருக்கும். அப்புறம் அப்படியே சரியா போயிடும் சார். என்ன பண்றது, எல்லாருக்கும் வர்றதானே. ஒரு 8 மாசத்துக்கு மேல.
Good evening everyone.
Good evening sir.
Good evening sir.
Sir, congratulations sir. Balashankar sir, dean ஆயிட்டீங்க. தேனி
வணக்கம். ஜாயின் பண்ணிட்டேன் சார். இன்னைக்கு தான் சார் ஜாயின் பண்ணேன்.
வெரி குட், சூப்பர்.
இன்னைக்கு தான் ஜாயின் பண்ணேன் சார். தேங்க்யூ வெரி மச் சார்.
நீங்க எவ்வளவு தூரம் அங்க போயிட்டு வரதுக்கு? half an hour ஆகுமா?
இல்ல சார், கூட சார் 1.5 மணி நேரம்.
அப்படியா? எவ்வளவு தூரம்?
75 kilometers சார்.
70 kilometers.
நம்ம டாக்டர் இல்லங்க, அங்க நம்ம சிவகுமார் இல்லங்க, அங்க தான இருக்காரு இப்போ?
ஆமா சார், சிவகுமாரன் இருக்கார் சார்.
அங்க தான் இருக்காரு. கரெக்ட். குட். நைஸ் டு see you all. Good.
Thank you சார்.
Sir, good evening, sir.
Good evening, Sivakumar. Good evening.
சிவகுமார்.
Good evening, sir.
போயிட்டு வந்துட்டியா?
Sir, leave தான் sir. இல்ல leave தான் sir.
லீவ் போட்டியா?
ஆமா சார், leave sir.
சரி
சார், தேனில தான் இது பண்ணிட்டீங்களா சார்?
அங்க தான் பேசிட்டு இருக்கேன். ஜாயின் பண்ணிட்டேன்.
ஓகே சார்.
I am sitting in the quarters.
ஓகே சார்.
இனிமே சாயந்தரம் மீட்டிங் எல்லாம் போட்டா வந்துருவேன்ப்பா.
ம்.
சாயந்தரம் மீட்டிங் போனா ஜாயின் பண்ணிடுவேன்ப்பா இனிமேலாம்.
ஆன்லைன்
May
தானே சார்.
not be possible in the weekend. வீக்கெண்ட்ல வீக் டேஸ்ல ஈவினிங் என்ன மீட்டிங்னா சரி ஜூம் மீட்டிங்ல அட்டென்ட் பண்ணிடலாம் பேசாம. ஒன்றும் பிரச்சனை இருக்காது. ஃப்ரீயா தான் இருக்கேன் சாயந்தரம். அது 5 மணி 6 மணிக்கு மேல கொஞ்சம் ஃப்ரீ ஆயிடும். டோட்டலா ஃப்ரீ ஆயிடும். இன்னைக்கு கவர்மெண்ட் ஹாலிடேங்கிறனால கொஞ்சம் ஒன்றும் அங்கே வேலை இல்லை, அப்படியே வந்துட்டேன் குவார்டர்ஸ்க்கு.
என்ன டெய்லி ஒரு மீட்டிங் இருக்கும் சார். ஆன்லைன் மீட்டிங் அங்கேயுமே மீட்டிங் இருக்கும் சார் உங்களுக்கு.
நீங்க எங்க இருக்கீங்க டாக்டர் இப்போ? டாக்டர் சிவகுமார் சிவகங்கை
சார்.
நீங்க சென்னையில இருக்கீங்களா?
இல்ல சார், திருச்சி சார். நான் இப்ப திருச்சி சார்.
திருச்சி.
ஆமா சார், சிவகங்கை எடுத்திருக்கேன். இப்ப ஆர்டருக்கு வெயிட் பண்ணிட்டு இருக்கேன் சார். சிவகங்கை கிட்ட மாறி இருக்கு. திருச்சி வந்து இப்ப சிவகங்கை.
திருச்சினா போயிட்டு வருது சிரமம். இப்ப டெய்லி போயிட்டு வரீங்களா?
ஆமா சார், டெய்லி போயிட்டு தான் வரோம் சார்.
சிக்னல் போயிடுச்சு சிஸ்டர்.
சிக்னல்லாம் இருக்கு
சார். இல்ல எனக்கு இங்க
நீங்க தெரியுறீங்க, நீங்க
we can
பேசிட்டு
start.
கேக்குது. No, how many participants in the delegate viewers list, ma'am?
Doctor, we cannot say that right now. It's a separate link, no?
Okay.
Share it after some time, after the event maybe. I'll share it in some time.
Okay. Is that okay? We'll start now.
Yes, please.
Niveda, ma'am.
விஸ்வநாதன் சார், குட் ஈவினிங் சார்.
சார் குட் ஈவினிங். குட் ஈவினிங். திருச்சியில் இருக்கீங்களா அப்போ?
ஆமா சார், திருச்சி தான் சார்.
டாக்டர் கார்த்திக், நீங்க மதுரையில் இருக்கீங்களா?
நான் மதுரை தான் சார். மதுரையிலே தான் சார் இருக்கேன். இங்கே தான் இருக்கேன்.
அது எனக்கோட சான்ஸ் கொடுக்க முடியாட்டாங்க.
வணக்கம் எல்லாருக்கும் வணக்கம். மதுரை எல்லா தலைவர்கள் எல்லாருக்கும் வணக்கம். மதுரை சீனியர்ஸ் எல்லாருக்கும் வணக்கம். நிவேதா ஆரம்பிச்சிடலாமா?
தட்ஸ் வாட் ஐ அம் ஆல்சோ திங்கிங் சார். சார் நிவேதாவோட லிங்க் ஏதோ ப்ராப்ளம் நினைக்கிறேன் சார்.
இல்ல சரி பரவாயில்ல. இந்த லிங்க் கொஞ்சம் அப்பப்போ ப்ராப்ளம் பண்ணும். ஆமா.
நிவேதா, இஸ் இட் ஓகே?
Sir, yes, sir. They told to start the meeting, sir. Sir, am I audible, sir?
Right,
you are audible. You can start.
Right, ma.
To the host, sir. They told they will let the people in, sir.
Okay.
Yes.
Yes, sir.
அவங்க இருக்காங்களா? வந்து DAP வந்துட்டாங்களா? Okay, they are there. I think you can start. And we can start now. Is it Rash? Who is that? The DAP for?
Hello.
Is it who is this for DAP? Who is that?
Sir, that is Ms. Shweta from DAP,
Okay,
sir.
thank you. That's fine. Okay, we can start. I think she says we can start.
Okay. ஆரம்பிக்கலாமா?
Sir, yes, sir.
நிவேதா ஆரம்பிக்கலாமா?
Yes, sir. Sir, sir. So on behalf of IAP Madurai, I welcome you all for this webinar on probiotics in the use of probiotics use in dysbiosis. So this will be the first meeting we will be conducting after our IAP president Government Theni Medical College. We welcome you, sir. So sir will be giving the welcome address for this meeting.
Respected Central IAP President, Dr. President-elect Basavaraja, Vinith Saxena, sir, Secretary General, and Upendra Kinjavadekar, President, sir, and the office bearers of Madurai IAP, and the seniors of Madurai IAP branch and other branches, seniors who have joined, and the distinguished speaker of today's webinar, Dr. M.S. Viswanathan. A very good evening to one and all, and I'm very happy to join and see and communicate through all of you through this webinar. Probiotics is a very, very burning and very, very important topic of today for two reasons. Number one, more and more awareness on the functions of probiotics are emerging day by day, and the etiological relationship between dysbiosis and so many disorders, starting from gut to the brain, so many disorders have been linked. So etiological cause for so many disorders have been linked to the gut dysbiosis. And moreover, the market is now being flooded with any number of products. Daily one company is coming and giving one product and promoting one product, asking for his our support. But we do not know exactly what are the probiotics which are really useful and what are the conditions in which they are really useful, and what is the dose, duration, and all those things. So selection of probiotic in specific conditions, and we should know the indications exactly. We should know the dose and duration of treatment, as well as not the least, the serious side effects of probiotics. Recently, I think FDA has come out with a warning that probiotics may do harm in the form of causing septicemia in very low birth weight infants less than 1 kg. So we should all remember this, and then only we can write down the probiotic in our prescription. To clear all our doubts, here is a person who is a qualified person, highly qualified person, a pediatric gastroenterologist, had adequate training abroad, and Dr. M.S. Viswanathan. Sorry, sir, the letters are very small and I cannot read all the things that is there in our CV. It is very difficult for me. He is that person, the central IAP member, EB member, and he has completed MRCP-CH UK, and he has got special training in pediatric gastroenterology, hepatology, and nutrition, liver transplantation, and in UK, London, UK, at King's Hospital. And he is a highly academic person who is really fit to talk on this topic. And he is invited reviewer scientific abstracts of World Congress of Pediatric Gastroenterology and Hepatology Association. SPECAR annual conference, he has given a talk, and he has been invited by SPECAR as fellow in pediatric therapeutic endoscopy workshop, pediatric IBD masterclass, pediatric liver transplant workshop in Croatia. And he has been invited speaker in national and international conferences. And he has won pediatric active pediatrician award in 2020. And this is a distinguished clinical tutor, Apollo Hospitals Education and Research Foundation award also. He has received that. So he has occupied so many posts in IAP. At present, he is a central IAP EB member and likely to be a EB member the next coming year also. He is a South Zone coordinator of the comprehensive nutrition module, CNM module of IAP, and he is a South Zone coordinator of this recent flagship program of our Upendra Kenjavadaka President SSS program of CIAP 2023. And he is the Treasurer Indian Society of Pediatric Gastroenterology and Hepatology and Nutrition chapter. And he is the Liver Transplant Society of India Executive Council member. And his special areas of interest are food allergy, pediatric nutrition, probiotics, IBD, and pediatric liver transplantation. He has written so many articles and published so many articles which have been published in distinguished journals. So he is the apt person to talk on this burning topic, probiotics on day-to-day use. Now I will hand over the mic to Dr. M.S. Viswanathan. You are welcome, sir. We are very eager to hear you.
Thank you. Thank you for a very kind introduction. Thank you very much. And Shweta, can you please allow me to share the screen? I think I need to, I was able to, yeah, I can do that now. Yes, thank you. Thank you. Thank you very much. And let me just put it the big screen. Are you able to see my screen in full mode? Let me just.
Yes, sir. Yes, sir. Yes, sir.
Yes, sir. Yes, sir.
1 second. Let me just make sure you do it properly. Okay. Yeah, I think Madurai Managara பெருமக்களுக்கும் அதை சுற்றி இருக்க எல்லாருக்கும் வணக்கம். என்னன்னா இது வந்துட்டு this talk we are doing for many cities across India actually, and so the thing is also we are coming with the IAP position paper on probiotics, which we are writing up. I was one of the authors there, which will be published probably early next year, I hope, actually. And we see the final stages. And basically, the idea is, as Dr. Balashankar sir mentioned rightly, I think so many probiotics, being brought into the market on almost on a daily basis, I would say that. And so let us go through, what sort of indications and how do we deal with these many products that are available currently in the market. So, that is it. I think I just move the screen this way. If this is hiding my view. Yeah. Okay, basically, if you look at it carefully, now I used to say like this, the last century belonged to antibiotics and this century belongs to probiotics. And that is the case, actually. The good thing about probiotics, in general, compared to antibiotics, comparatively slightly less side effects. It's not that it's not going to have anything, but it is to some extent compared to anything else. And so if you look at very carefully, the studies just done from 1983 to 2020, if you see that, there are more than 3,000 studies. But in the last 7-8 years, you see that significant number of studies being done around 3,000 odd studies just within the last 8 years or so. So that is what is happening nowadays. Just 1 second. So the number of studies that has been going on in probiotics is quite a lot. And that is the reason why we have so much of probiotics being brought into the market, and there is so many indications being brought on. But again, we have to be very careful in choosing what probiotics we have to give in which conditions. This is what happened in the past. Is it a heap or high? And let us try to see whether what is actually the rationale behind giving probiotics for many conditions. Okay, we have to know the indication first of all, and then of course we need to talk about the probiotic in question. Is it a single strain or a multiple, and what is the dose? And of course we need to look at this data that is available from various parts of the continents, and then we have to see whether this basically the analysis, if you look at very carefully the studies, whether this is industry influence. That's one important thing. Whenever you look at the study, you have to look at the conflict of interest. And if an author discloses the conflict of interest, that's actually good news, actually. There is nothing to hide there. So people have to disclose the conflict of interest. There's nothing wrong, but they have to disclose exactly what's the conflict of interest. And they need to very clearly say what sort of the industry's influence in the paper, whether even they are involved in methodology, etc. That's very important to know that. And that's the reason why, we need to be extremely careful in giving the probiotic for the right conditions. I mentioned about this one, about the disclosure stage is very important. And then also look at the funding source and what sort of funding has been done. And also look at the our own data wherever it is possible. And of course, we are dependent on data from other parts of the world also. So before I start probiotic, the whole point of, the probiotics being come into place is because of the gut microbiome. What is happening in the gut microbiome? As you all know that the human intestine holds the largest number of microbiome compared to any other part. And compared to even human cells, in our own cells, the microbiomes actually, they are significantly more in number. They're in 1 trillion microbiome in our GI system, actually. And in fact, now probably we can say that's the largest organ in our GIT or in our entire body. So that's the nature of the microbiome. And because there is an alteration in that, and there is various disease states, and because of that, the studies have come into place, giving the right amount of right dose or right sort of probiotic. And that's how things are come into place. But if you look at very carefully, there are apex predator. If you look at jaguar in South America, it's an apex predator. It kills even anaconda. You will be surprised. It kills crocodiles. If you take away the jaguar from that particular ecosystem, what will happen? The entire system is altered. So that's how it is. The microbiome, you need to have the right amount of microbiome. And similarly, in one of the states in US, they were having a lot of wolves in particular forest. If they remove the wolf, the herbivores were predominant. Then they were left with, there is no grass in that. Even the herbivores couldn't survive that. So the ecosystem is very important. And that is the reason the microbial diversity is not only microbiome, microbial diversity is very important in our body. And that's how, when there is an alteration in that, either through sort of, cesarean section, or through formula feeding, or through giving too much of antibiotics, all this alter the ecosystem. And particularly the diversity is lost. And that's where the disease states occur. And that's what we are trying to rebalance with giving probiotics appropriately for that particular condition. So as of now, the very well studied indications for probiotics are infection, particularly acute gastroenteritis across various parts of the world. And to some extent, nosocomial diarrhea, which is hospital-based diarrhea, or antibiotic associated dysbiosis. These are the predominant indications. The probiotics have been studied very well. Recently, a lot of studies have come on functional GI disorders, and particularly infantile colic, and also on, to some extent, on constipation. And there have been some studies on allergy and immunity. We'll discuss about that. So there is actually an interplay between all these things, Th1 helper cells, Th2 helper cells. There is an interaction that goes on, and when there is one predominance, you have a dysbiosis, and there's another one predominance, you have a eubiosis, and that's what is important. So probiotics can be used mainly for therapy purpose, but there is some role for prophylactically. We'll discuss that. And also we need to balance with the efficacy and the safety purposes. And as Dr. Balashankar mentioned, there was a recent article about the FDA alert on particularly using probiotics in preterm infants. And then and we'll discuss it through the next few minutes or so. So NEC, if you look at NEC, you all basically encounter NEC quite frequently in your day-to-day practice in neonatal, as a neonatologist or even as a pediatrician. And then basically what's happening here is basically an immature intestinal barrier, and there is an immature gut immunity. The most important is an altered gut microbiota. And because of the immature intestinal barrier, there could be a translocation of the bacteria, which results in sepsis, particularly late onset sepsis, which is quite high as 20% in very low birth weight babies. So, and the incidence of NEC varies from 22.6 to 28%, as the studies quoting from many parts of the world. And obviously it's much more preterm, which are vulnerable. And mainly because the microbial diversity is poor, the ecosystem is altered, and also the acquisition of microbiome is slow as they have come early, out of the mother's womb. They have more of Enterobacteriaceae, ran less of Lactobacilli and Bifidobacterium, which are a predominant bacteria when you look at the normal, full-term vaginally delivered babies, or also in breastfed babies. You have more of Lactobacilli and Bifidobacterium. So all these things, and there are many other components, necrotizing enteral can have mortality as high as 20 to 30%. And some of them may need surgery also. And that was one of the reasons a lot of articles, probiotic studies have happened, whether we can do something about this to prevent NEC and also the late onset sepsis. Can we treat and prevent the poor outcome? And that's the reason why a lot of studies also has been done, in particular this aspect in preterm babies. So let us look at the case scenario. A 2-day-old female baby born at 34 weeks referred to NAC due to bloody stools. The spontaneous delivery, vaginal delivery, after induction of labor for preeclampsia, with a good ABGA scores, with a base deficit of -7, basically metabolic acidosis there, receives standard newborn care, including vitamin K, and otherwise uncomplicated antenatal period, and the family issue was fine. There is no any significant antenatal or even the peripartum history, apart from the ankylosing, the tongue tie for the child, which was released. So I just want to know, which factor do you consider most likely contributing to the 2-day-old preterm infant bloody stools in the present case? Is it the maternal health during pregnancy? Is it the delivery-related factors? Is it the breastfeeding and formula feeding practices? Is it possibly GI issue in this infant? Go back to the case. It's uncomplicated pregnancy, family history was unremarkable, and spontaneous vaginal delivery. There was no any major, issues in the mother's health-wise. But what we are seeing here, basically, the feeding-wise, it says basically doesn't say much about the feeding. So So we need to know what's going on here. Is it just this? So we know that there is no room for interaction, unfortunately. There is no mental health is fine. The delivery is not a big factor in this particular case. It could be a combination of breastfeeding or formula feeding practices, or could be basically an inherent GA issue in this patient, because this baby has come preterm. Probably there has been issue with the microbiome diversity, and there is a delay, obviously, in acquisition of that. So, as I mentioned earlier, there has been a lot of studies in probiotics, particularly, and there has also been, studies from a review by Cochrane, and also network meta-analysis have been done. And recently, there is also a meta-analysis, and particularly on NEC, which is probably is not included in this presentation, which is published as late as just this couple of weeks ago. And so basically, the problem is, the heterogeneity in the studies. That's the main problem. The time of initiation of the probiotic and the strain and the gestational age, the birth weight. Multiple interventions happen in neonatal period, starting in the inhalation, giving surfactant, so many lines and so many things happening, and then maybe an IVH. So many things goes on. So all these things are a confronting factor. Also, unless all the studies addresses these issues, it's very difficult to draw a homogeneous conclusion from these recommendations. So basically, this is one study, basically a network meta-analysis, as I mentioned, for published in 2018. And they included around 11,200 odd preterm infants. And if you see the studies, many of them included Bifidobacterium species. It could be Bifidum, or it could be a longum. Some of them a combination probiotics, some of them 1 or 2. And if you look at very carefully, most of them did have 3 or 4 probiotic strains. And one of them was Lactobacillus rhamnosus GG. So a lot of infants have been included in these studies. But however, as I mentioned earlier, because of heterogeneity, there's only few studies were eligible. Do you all agree the probiotic is safe for a preterm infant with NEC? I am pretty sure many in the audiences might be using the probiotic strains, has been recommended recently, and I'm sure that you will be able to have a say in this also. But as of now, will we say it's safe? Well, probably yes, as of now. So let us say what happens in the ESBAGAN, European Society. They state that it's safe with a low certainty in the evidence. The only thing is, as recently was an FDA alert, you need to be careful, particularly using each species, and particularly so if the baby is very preterm, very low birth weight, and particularly they have a long line in situ, because the risk of the translocation, particularly, is much more with the yeast bacteria, yeast probiotic compared to the bacterial probiotics. So one has to be very careful about that. And also we need to make sure that none of the probiotics should produce D-lactate. You all know that they can resist D-lactic acidosis, which is again is not a good sign for the baby. And obviously they should not have any resistant capability, the probiotics. And of course, the analysis has to be very important. Whenever you're going to use a probiotic in a preterm, particularly, obviously, it's not going to be easy. You need to have a concern from the parents, particularly the first child. They undergo a lot of stress, and the baby is already preterm. They may not be willing to have their baby, to put to the study. So one have a lot of difficulties, particularly in this group of patients. So the comment on ESBAGAN is the Lactobacillus rhamnosus, this particular GG. This is a common strain which has been used for many indications, ATCC 53103, and they have found that they have reduced the stage 2 or stage 3, but the evidence is again low certainty of evidence. Similarly, the combination of Infantis, Lactis, and Streptococcus thermophilus, this 3 combination is reduced to stage 2 or 3. And again, there is no particular combination of singular combination. No optimal duration is known. 4 to 6 weeks until discharge is acceptable. And again, the other studies, they looked at the regulatory. There's no role for that. This again, this 2 combination of bifidum and lactobacillus lacidus, again, no role. And there has been a negative recommendation for the standalone probiotic strain Bifidobacterium brevi BBG001. And again, as I mentioned earlier, a negative recommendation for Saccharomyces boulardii, which is basically an yeast probiotic, because, as I mentioned earlier, if you look at all the studies which has been done, numerous studies the last few decades, hardly you see any amount of side effects actually to probiotic. They're actually safe. Apart from this, a few instances of septicemia, with yeast probiotic, particularly in preterm babies and maybe in other children who are immunocompromised. One has to be very careful, particularly immunocompromised. I try not to use any of this probiotic in any of my patients who has got chronic diarrhea, whom I suspect enteropathy, who is having failure to thrive, whom I suspect immunodeficiency. I really do not use in those children at all. So, probiotic strategies to prevent NEC in preterm infants. Again, this is a meta-analysis. This was published in 2019, and overall reduction around 3.5% for overall. The combination strain, is seems to be much more useful to prevent the late onset sepsis. The number needed to treat is around 44 babies. The best outcome was in children less than 32 weeks and less than 1.5 gram. American Gastroenterology Association, if you look at very carefully the history of American studies and European studies, usually they contradict themselves in many of these recommendations. Basically what they say here is, for this particularly, good news is they have recommended initially actually, but in the combination probiotic in children, babies less than 37 weeks, low birth weight infants, they suggest using a combination of lactobacillus species and bifidobacterium species. You can see all those strains which has been put up there. But again, in this particular statement was highly recommended actually from American Gastroenterology Association, and this was in 2020. What are the gaps in research in preterms? Now, as I mentioned, it is difficult to do a placebo control studies, and it's not going to be easy, but you cannot compare two different probiotics. It's just not possible. And we need to have more data in extremely low birth weight babies. And of course, we need to know the mode of administration and long-term safety. That's much more important. And I think the one problem is, we may not be able to, generalize a particular strain from one continent to another. But though we may be forced to do that, but we may have to have our own studies. So acute infectious diarrhea, as I mentioned, it is one thing which has been studied extensively for the role for probiotics. And again, this is very interesting. If we see the Eastern Europe, they are proponents, whereas the Western Europe and mainly the Northern America, they have slightly against a contradictory view for the use of probiotic in acute infectious diarrhea, particularly the North American studies. Let us see why. Is it something to do with the role of pharma? Is it something to do with the case that has been enrolled? Let us see what it is about. And again, the problem here is we are stuck in between. Actually, though we are ideal ground for research, unfortunately, not many, though we have been doing quite a few nowadays, but there has been not that many compared to studies happening in Western Europe or in Northern America. So, but again, the problem is the heterogeneity of studies wherever it is happening across the continents. So, again, as I mentioned, because of the low income to high income, the severity of diarrhea, the immunity status, the nutrition factors, again, whether they looked at the viral, whether they used a probiotic for viral etiology, whether there was a predominant bacterial etiology, or whether there was no obvious etiology identified. All these things do play a role. So intervention factor actually also important. Or if you intervene very late, you may not be able to see the effect of probiotic. Or if you're intervening early, well, you may be able to see. So is it and single versus combination, again, very important, the strain, the duration, the type of trial, and again, the methodology issues. As a simple, brief case scenario, a 3-year-old child with loose stools, 5 to 6 episodes with the pain and nausea for 1 day. And then the pain in the abdomen was followed by loose stools. And there was no other history, no blood in the stools particularly. The family history was unremarkable. There is no contact history. Vitals fine. Diarrhea was there, but there was no any dehydration. Otherwise, the examination was unremarkable. So what is the appropriate course of action for this case? If you look at carefully, this is only, a 3-year-old girl with the diarrhea going on for, probably 1 day, 2 days. And then, otherwise the child is systemically well. So we can continue the probiotic treatment as prescribed while closely monitoring the patient's symptoms, but we need to know what probiotic the child was receiving and perform additional tests if needed when this child is not having any sort of dehydration. Most of the stool analysis is actually useless test. And that is the case even I found in my own hospital. And consider adjusting the probiotic dosage or switching to a different probiotic strain patient specific condition. Of course, that we need to think about that. or provide supportive care. Of course, we need to make sure the child gets ORS, child gets zinc, all sort of things is very important. So I think particularly for diarrhea, what are the outcomes you are looking at is whether there is a reduction in the duration of diarrhea, whether there is a reduction in the consistency of the stools, and of course, the most important parameter for those countries who are predominantly funding the healthcare. For example, country like UK, their National Health Service provides the 97 to 98% of the healthcare in UK is provided through the government by NHS. So there, what is more important for them is to see whether they can get out of this, you can discharge the children sooner. That is also a very important parameter for any healthcare system, because that is the health economy. So most of these, you all know this, for the diarrhea studies, usually use the modified Vesic-Harris scale, which has the diarrhea, the vomiting, the body temperature, the severe dehydration, the treatment, and of course, you have a grading, you score less than 7 mild, 7 to 10 is moderate, and more than 11 is severe. So the statements from ESPAGAN is GG, lactobacillus GG, which is a very commonly studied as with Saccharomyces boulardii. They do have a recommendation, but it's weak recommendation. But it is a conditional recommendation, and I will not say strong recommendation for lactobacillus rutili, particularly for diarrhea. And Bacillus clausii, there has been some studies, ESPAGAN initially came in some sort of not strong recommendation. But then after that, few studies have been done. There has been some recommendation, though it's weak, again for Bacillus clausii in the role of treatment for acute diarrhea. But interestingly, this 2022 statement very clearly gave a negative recommendation against this combination of probiotic, Helveticus rhamnosus and Rhamnosus and reuteri. These two particular combinations was found to have a negative recommendation, so better not to use them. So American gastroenterology, interestingly, they did look at all this, the same sort of probiotics which has been studied in European countries. And though they say there has been some sort of decrease in duration of diarrhea by 21 hours, they suggest against the use of probiotics, and they say is more with the conditional recommendation. The reason they say is, but the problem here is you cannot sometimes compare these American studies with the European studies, because what has been postulated is, I'll come back to the next slide, lactobacillus GG, the RCT, Journal of Nutrition. Here, this is the study they are quoting. Actually, there was no benefit. Similarly, this we have discussed about that. This particular combination has got no benefit. So basically, what is happening in American studies is, the European people say that majority of those of their patients were immunized with rotavirus, so they don't have rotavirus diarrhea, and because of that, probably the probiotics is playing a limited role in their population. But again, they say that the probiotics were given after 48 hours of diarrhea, when probably their role is limited. And most of them are given liquid form, and the viability has been an issue there. And some of them has been exposed to antibiotic. These were the issues which was raised by the European group when the negative recommendation came by the was given by the American group. So that's what is happening. So, but overall, from the European perspective, compared to this is the lactobacillus GG. If you use a dose of more than 10 to the power of 10 colony forming units, there has been a reduction in the stool volume, and there has been a reduction in hospitalization, and at least by 24 hours. 24 hours is a good what to say number of hours for a country like UK or Germany, France, Spain, which are predominantly the government healthcare run systems. The reason is, if you might know that in bronchiolitis season, honestly, I was there, we are pushed for beds. It's not you are going to discharge every 24 hours. We may even end up discharging children every 6 hours to get the bed availability for other patients. So that is the nature of the bed stress in those countries, particularly during busy winter seasons. So that is the reason even the hospitalization reduction duration of 24 hours is very significant. So Indian data, and again, there has been reductions, the meta-analysis around 2 studies, the reduction duration again by 24 hours. Again, this more than 10 to the power of 10 dose is most important. And they found similar performance in Asians, as in similarity with Europeans, and most effective if the probiotics introduced within 72 hours of diarrheal onset and better in rotavirus diarrhea. So Saccharomyces boulardii has also got a lot of studies, particularly for acute infectious diarrhea. They do do very well in the reduction of stool volume, reduction of the duration of diarrhea, and again, the most important also, it seems to reduce the episodes the following days also. Bacillus clause, as I mentioned earlier, similarly, they reduce the duration a little bit less than the rhamnosus or boulardii by probably around 9 hours. Again, reduction duration of hospitalization by by less than a day. So recovery from diarrhea was achieved by 97% of the patient, as by a study by Lahiri et al. And the total treatment cost, was 472 rupees, when you use a probiotic compared to ORS. That need to be considered. But if you consider the hospitalization again for the patient losing the parents losing the work, etc., this may be significant also to discharging early. So again, this is a represented by heterogeneity, and that is the reason why we're having difficulty in drawing conclusion. The Luteri was not studied very well, particularly for the diarrheal indications, and that is no studies particularly from India for diarrheal indication. So if you look at the studies so far for all these things for the diarrhea, Rhamnosus GG and Saccharomyces boulardii and to clausi, there has been some mild to moderate exiting level of evidence to use in acute diarrhea. So, and this is the pooled data from both from India and outside the country, and the same sort of indications. I would definitely say Rhamnosus GG, Saccharomyces boulardii, and clausi. I personally have not used lactamyces DSM 17938, particularly for diarrhea. So, but though there has been some very low level of evidence, and so obviously there is no role for combination probiotic in diarrhea. That I can say that. Recently, we have seen people bringing out the combination of Saccharomyces and lactamyces Rhamnosus GG. How far it is good, we don't know. And the most important problem with this combination probiotics is actually if you measure them, they say this has got this much of colony count, this much of so many things. But if you actually do a lab analysis, they don't really have that many colony counts. And that is another problem. We need to have the correct amount of colony counts for it to be effective. There has been studies done very well in antibiotic-associated diarrhea, C. diff, nosocomial, and IBD. Do you agree that probiotic supplementation reduces the incidence of severity of AAD, CD, and nosocomial diarrhea, or exacerbate symptom patient antibiotic treatment? We will discuss that rather than agree and disagree. We will discuss that. For C. diff, the American Gastroenterology recommendation, it's a conditional recommendation, low quality of evidence, and then they say that you could use that provided that you need to carefully analyze the cost-benefit analysis. Particularly, Saccharomyces boulardii has been used for this particular indication, Clostridium difficile diarrhea. The reason this C. diff diarrhea has been studied extensively is this is one of the important parameters. For example, when there is an hospital inspection by our accreditation has to be given, they need to see how many of their patients had healthcare associated infection, and one of them is C. diff diarrhea. If there is an incidence of C. diff diarrhea more in a particular hospital, that particular hospital gets a bad name. So that is the reason this has been taken into account, and people have used this one extensively. And Saccharomyces boulardii to some extent have been found to have a role in C. diff diarrhea, and some studies have also recommended Lactobacillus rhamnosus GG. We'll come back to that. So in other diarrheas, I mentioned about C. diff, IBD, there has been no definite role for probiotics, apart from a particular subset of patients who has got pouchitis. This is basically a condition which an inflammation of the pouch, which has been created following a surgery for particularly UC, an ilioanal pouch, following, and this particular probiotic called VSL-3, which is a combination of 8 probiotic strains have been used for this particular condition. However, this has to be used very carefully. Again, and this you need to definitely get a specialist opinion before you use that one. And I will definitely say there is no role for probiotics in chronic diarrhea you need to address the underlying cause, and the nutritional rehabilitation is much more important than the role for probiotics. And nosocomial diarrhea, I did mention C. diff diarrhea. Saccharomyces boulardii has got more role, whereas for nosocomial diarrhea, for other reasons, you have a role for lactobacillus rhamnosus GG, which has been studied, to a greater extent in European countries, and this is moderate quality of evidence with a strong recommendation. And of course, many of the studies are pharma funded, and there is no role for Rotary in this particular condition. Allergies, my actually exposure to probiotics allergies is limited. I do not use them, though I see a lot of food allergies. I see common cosmic protein allergy very commonly. I see egg allergy. I have many of my patients who was treated for atopic dermatitis found to have a cosmic protein allergy as the reason for the significant atopic dermatitis. Many of my patients do have an overlap of this atopic march. They do have food allergy, asthma, and allergic rhinitis. But what is the evidence from the studies? Let us see that. Eczema, atopic dermatitis, actually there is no role, from one of the studies. There has been some role with, say, some studies says yes, but majority of the studies have found no role for probiotics in asthma or food allergy. Functional disorders, infantile colic is one of the important subset of these disorders, which has been extensively studied for probiotic role. And this particular, study from Sajeska, she is a reputed author from Poland, and she also takes the lead in the probiotic study for the European Working Group on Probiotics. And I was fortunate to meet her. In fact, I moderated one of her talk recently for IAP. And there's also a study from Savino, he's based in Italy. These two authors have studied a lot of babies for infantile colic. And basically, the study from Sajeska mainly found role for breastfed infants. They did not find a role for, the probiotic Lactobacillus reuteri in formula fed infants. And this is basically a study when they used it, basically 50% exclusive breastfed, favorable outcomes, at 30 to 90 days, particularly the colic. And there is no role, as I mentioned, for irritable bowel syndrome or functional abdominal pain. This is studies have been looked into that. It's very difficult to draw any sort of conclusion for these two disorders. I know it's not easy to diagnose them, first of all, and then to use probiotic and to study them is not going to be very easy. But again, many studies have been done. They did not find any role compared to placebo, particularly the role for probiotic. There is no role. So in summary, we did discuss in detail about penicillin, acute infectious diarrhea, then C. diff, nosocomial diarrhea. Then we discussed about antibiotic-associated diarrhea. We didn't discuss too much about that. I will talk about it anyhow. And that is part of a C. diff diarrhea. And then we discussed about the role in food allergy eczema. So let us say, what is actually the hip or high? High modest evidence actually for preterms or NEC combination strains. And the antibiotic therapy for the prevention of C. diff, you can use single or combination. I think, for example, I have patients who has got H. pylori gastritis, which is very much confirmed. I will be using antibiotics for 2 weeks at least. Some of them, if there's history of diarrhea for some of these antibiotics, I may start at the same time, but not necessarily for other patients who was having diarrhea, who's going to have antibiotic for 3 or 5 days. I mentioned earlier, pouchitis is a specific condition where a VSL-3 has got a role. And the low to poor evidence, because we did discuss about Lactobacillus rhamnosus GG, Saccharomyces boulardii, and Bacillus clausii. They do have a role. You could use them. The reason you could use them, I'm saying that is because the adverse effects of these probiotics in these children, is practically unknown compared to those that has been used on preterms for other indications. And for personal recommendation, I won't see any much role for eczema or atopy, though I have seen people using that. Infantile colic, yes, there is a role for reuteri. Particularly studies have recommended in exclusively breastfed infants, not necessarily in formula fed babies. And definitely there is no role as of now for IBS or functional abdominal pain or food allergy, definitely there is no role in chronic diarrhea. Please do not use in chronic diarrhea. As I do, you see people being used in those particular indication. There is definitely no role for IBD. Yeah. So that's where my talk ends. Actually, I'm happy to take any questions. Thank you very much for your patient listening. And we want to keep it short, as this is basically a national. This is also happening at the national level. Also, we need to be precise to the talk. Actually, thank you.
Thank you, sir. Thank you, sir, for sharing your valuable knowledge with us. Sir, I do have some questions.
Yes, please. Yes, Dr.
Sir, you are talking about antibiotics. Like we can give probiotics when the child is on prolonged, it's on antibiotics, for example. So, is there any to prevent Clostridium difficile infection? So, is there any particular duration, any suggestions regarding that? Like, so how many days if we give antibiotic, we can start probiotics? Is there any recommendations on that?
And again, it also depends upon the type of antibiotic you are using. For example, amoxicillin group, penicillin groups, cephalosporins, the risk of diarrhea is high compared to macrolides. So if you are going to use macrolide, the risk of diarrhea is less. For example, in the treatment of H. pylori, I may have to use an amoxicillin or metronidazole or clarithromycin. I have to use one of them. I mean, two of them at least. So in those, I have to use for a period of 14 days. Sometimes I may have to use 2 or 3 days after start of antibiotics, or I tell my patients, when they start having loose to start used, and then if they can afford, I will prescribe. If not, I won't do that. But I will not definitely prescribe them if I'm going to use a duration of 3 days, 5 days, or if I'm just going to give macrolide group of antibiotics. The risk of diarrhea is much more with those things, and compared to what's the macrolide, is less. To some extent, clinical is less. Very high with amoxicillin, clavulanic acid, and cephalosporins, as you all know that.
Okay, thank you, sir. Sir, hello?
Yes. I can hear you, yes.
Sir, recently there was an issue like in US, there was a neonatal death following an...
Correct. This was a study quoted by the FDA for Bifidobacterium brevis. That's the one, I think. And I think I'm just looking at that also. But again, if you look at this, another paper come up just literally after that FDA alert was introduced. And that was, again, if you look at that, I will tell you, I will quote the study, which we couldn't include that study here. But that study, you all can see that was particularly looked into all this. This is a study published in JAMA just last week, October 2023. And this was by Wang, W-A-N-G, Wang et al. Group. This is an original study. And basically in this study, the study is basically probiotics, prebiotics, lactofferrin, and combination products for prevention of mortality and morbidity in preterm infants. And this was a systematic review and network meta-analysis. Their conclusion was basically there was a moderate to high certainty evidence demonstrated an association between multi-strain probiotics and reduction in all-cause mortality. And these interventions were also associated with the best effectiveness for other key outcomes. Combination products, including single and multiple strain products, combined prebiotic lactofferrin, were associated with the largest reduction in morbidity and mortality. And if we looked at the very careful discussion, they went for a combination probiotic rather than a single strain probiotic, particularly for NEC preterm. This study, you may have to go through that, because just because with one alert, we cannot go for knee-jerk reaction. We have to look at the other studies also, very important. So if you look at the large volume of studies, please do look at this study. I will also forward the study to the group. You can just share with the other people also. This was published JAMA Pediatrics, just online, October 2020, September. It's come that October. I will send it to you, because we are discussing about this, the paper which was the FDA alert which was issued, and following that we have discussion about this particular paper also. I will forward that to you. I will look at that.
Any more questions from? Hello?
Yes, Dr. Niveda, yes, thank you. Your voice is a bit patchy, but I can hear you. Yes.
Sir, I have a question, sir. Simple question. I'm not sure.
Yes,
Sir,
yes.
do we need to refrigerate this probiotic sachets or the tubes, sir? Do they lose potency if we keep them in an open room temperature?
It all depends upon the manufacturer recommendation. If they say yes, we have to do that. That's for sure. And most importantly, many of them can be kept in a room temperature, not necessarily.
Okay.
The problem is, Tamil Nadu, we have hot weather, very hot weather, extreme hot weather. We really don't have a cold season at all. Probably we need to be much more careful in our state when we have to probably store in a better way, actually. Because our sunset and sunrise is almost the same throughout the year. Probably an half an hour difference in May compared to December. We don't see much difference at all compared to northern part of India. We have temperature running around 30s most time of the year.
Okay, thank you, sir. Thank you.
Sir,
Yeah.
so I'm just asking, sir. I think there are no more further questions, sir. Hello?
Yes.
Yes, sir. So thank you, sir. Thank you once again for sparing your valuable time and educating. Sir, am I audible, sir?
Audible, yes. Now you're audible.
Yes, sir. I would have.
Thank you. Anyhow, sorry, Niveda, I think your probably your network is patchy. I think don't worry about that. Thank you very much indeed for hosting. And then thanks a lot to Madurai team. Madurai Makkalukku, Madurai Managara, Matham and the branch Ellarkum Vanakkam Nandri. Anyhow, I'm happy to take any questions if you some more time. Really nice to see all of you. The one thing is, whenever you use a probiotic, my personal thing is just review 5 days, 6 days, stop it. Just stop it. Don't keep giving more than 5 or 6 days. This is my personal suggestion. If you want outside the my talk period, this is my personal recommendation. Give 5 days, 6 days. Don't keep on giving them. They may not need it. But first of all, two things. One is a bit expensive, and we don't know whether it's indicated for that long. Another thing is, its cost factor is there, for the family. We don't have to give it longer period, but definitely there is a role for 4 days, 5 days in diarrhea that I mentioned actually. Nothing wrong in that. But long-term role, I don't think it's needed. No role for constipation, definitely, as of now. No role for constipation at all. Shall we finish, Dr. Nivedita?
Yes, sir. I think we can wind up, sir. Thank you, sir.
Host is Shweta there? We'll find out Shweta. Is there any other questions from any other platform? Let us know, Shweta.
No, doctor, no questions.
Any other platform? Okay, that's fine. Thank you very much. Thanks for hosting us, and thanks, Madurai team. Thank you very much. Nandri, vanakkam.
Sir, I think we can wind up, sir. Hello? Sir, I would like to thank Dr. Balashankar, sir, Dr. Navamani, Dr. Karthik, sir, Dr. Shivakumar, sir, Dr. Arun Priya, ma'am, Dr. Venkatramanan, sir, for joining in this meeting, sir. Thank you, sir.